Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Ryan Topping. Today's episode features Dr. Othman Al-Sawaf from University Hospital Cologne in Dusseldorf, Germany, and the Francis Crick Institute in London, and Dr. Lydia Scarfò from the IRCCS Hospital San Raffaele in Milano, Italy. They will be discussing recent data presented at EHA 2022 on the use of BTK inhibitors for CLL and MCL. This episode is part of a larger educational program titled A Global Perspective on BTK Inhibitor Therapy Data for CLL and MCL in 2022. Please visit the show notes for this episode for a link to the complete program, including downloadable slide sets and additional expert podcasts. Now let's get started and hear what the experts have to say.
Hi everybody, I'm Lydia Scarfò from Università Vita Salute San Raffaele and San Raffaele Hospital, Milano, Italy. And today I'm going to discuss with Dr. Othman Al-Sawaf from the University Hospital of Cologne, Germany, the most relevant abstracts presented at last EHA Congress on BTK inhibitor-based treatments in patients with chronic lymphocytic leukemia and mantle cell lymphoma. So let's start discussing late-breaking abstract that was presented on the analysis of the CLL-13 trials. I know, Othman, you were part of the study, so what are your take-home messages from this work?
Yeah, thanks, Lydia. It's a pleasure to do this podcast together with you. Yeah, I think CLL-13 definitely has a lot of key insights that on previously unaddressed questions. I think, first of all, of course, one of the primary aims of the study, trying to demonstrate or to explore whether fixed duration targeted treatments can be superior to our most effective chemoimmunotherapies in young and fit patients. This key question can be, I think, answered very nicely with this study, as it clearly now has shown that venetoclax in combination with obinutuzumab, with or without ibrutinib, provides a longer progression-free survival than chemoimmunotherapy with FCR or with BR in young and fit patients. And although we've been using venetoclax obinutuzumab now for a couple of years, also in young and fit patients, as it is labeled and approved for this group of patients as well, in the frontline setting, we didn't have so much robust randomized data so far. And so the CLL-13 study has certainly confirmed that, also based on the deep minimal residual disease clearance that we can achieve with this backbone of venetoclax and obinutuzumab, that basically all patients in the frontline setting do benefit from this substantially, both in terms of achieving deep remissions as well as getting really long-term disease control. At least as far as we can tell from the current median observation time, which is around about 28 months at the moment. So follow-up analysis in the upcoming years will hopefully also provide more insights into the durability of these remissions, also, of course, across the different subgroups that are of particular clinical interest.
For me, what was striking in the presentation is that probably there is no room anymore for chemoimmunotherapy, even in the first-line setting, because, we have very effective time-limited regimens that can be applied also to young patients with long-term disease control. So I do not see any reason for exposing them to the risk of long-term adverse events like myelodysplasia or acute leukemia, instead of administering targeted time-limited agents. And also the second issue is the triplet better than the doublet. What is the addition of ibrutinib adding in terms of disease control or depth of response? Is it worth doing that? Because if I correctly recall, there is a higher incidence of adverse events in the triplet arm, so I'm not sure is it worth doing that, in your opinion, Othman?
Yeah, thanks, Lydia. It's a great point. I think we can't say for sure at the moment. So far, the addition of ibrutinib to venetoclax obinutuzumab did not really yield statistically significant advantages, either in the terms of the MRD response rate or the rates of undetectable MRD. So the end of the treatment, we saw in the peripheral blood after venetoclax obinutuzumab in this study around about 86-87% undetectable MRD rates. And with double combination, with the triplet combination, it's slightly higher, around about 92%. So again, it's slightly higher undetectable MRD rates, but just a few percentage points, probably not really clinically significant. And also when we look at the moment at the progression-free survival rates, we also, particularly in patients, for instance, with an unmutated IGHV status, the PFS rates at 3 years are slightly higher, again, just a few percentage points, again, 87% 3-year PFS in the unmutated IGHV group with the triple combination, 83% with the double combination. So it seems so far that these, usually when we look at PFS, also in the context of CLL, these mild differences are usually not clinically significant, or at least not sufficient to guide us in our clinical decision-making. So for now, I would say we don't see robust evidence to support the triple combination, at least within CLL13. Of course, there are a lot of discussions and also studies done for the patients who have TP53 aberrations, which are not included in CLL13, whether in this group of patients, the triple combination might be possibility to increase efficacy for fixed duration treatments in patients with TP53 aberrations. This is something that still remains open, but I think CLL13 so far does not support triple combination use.
Speaking about combinations, at this last EHA meeting, the updated results of the FLAIR study were also presented. And the study at this point is comparing treatment with ibrutinib monotherapy with the combination of ibrutinib plus venetoclax, and the results of the interim analysis presented at EHA were based on the comparison of MRD rate. So I thought it's quite a weird endpoint, considering that one of the arm is ibrutinib monotherapy, which we know only anecdotally obtains undetectable MRD. So the results confirmed a great advantage of the combination of venetoclax plus ibrutinib in terms of undetectable MRD in peripheral blood and bone marrow, while 0% of the patients receiving ibrutinib obtain undetectable MRD. So it seems that the combination of ibrutinib plus venetoclax that was now tested in different settings, fit young patients, elderly patients, is the combination we are going to use in the future. What are your thoughts on that?
Yeah, I think the FLAIR study is a very interesting study because it tries to address so many different questions and so many different research hypotheses. I think it definitely is a great effort in trying to do in a randomized setting a really MRD-guided approach where MRD is not just observed, but actually used to decide on treatment duration, and also not just based on one single assessment, but rather on the dynamics and of minimal residual disease. So the study specifically in its protocol designs treatment duration based on how long it took the patients actually to get into undetectable MRD, and treat the patients accordingly with a slightly longer treatment duration. So it's a very neat study design in of it all. And what I think is so far interesting, of course, again, the clinical conclusions we can make here are a little bit limited because we don't have any time to survive the event data, no survival data as of yet. So we can't really correlate any of these MRD responses or non-responses to the outcomes of the patients. We need more events and longer follow-up for this, as Peach also said at his presentation. But I think it's very clear now that with 1 year of ibrutinib plus venetoclax, the undetectable MRD rates will remain around about 50 to 60% at best. 55% has been observed in other phase 2 studies, and also in the GLOW study in the peripheral blood after around about 1 year of treatment, which is, of course, as we've all seen before in CLL13 and also in CLL14, lower than what we see with the combination with the CD20 antibody. Again, we can't really say what does this mean for the patients, given that we don't know how much this affects PFS in the long run, at least for now. But I think here in the FLAIR study, we clearly see that if you extend ibrutinib plus venetoclax, you can increase the rates of undetectable MRD quite substantially. And we see that also in the observations that were made in this study, that the median time to MRD negativity with ibrutinib plus venetoclax is 12 months. So if only half of the patients achieve undetected MRD within a 12 months, it means that clearly there is a rationale to treat longer when you want to do the all-oral combination of ibrutinib and venetoclax. So I think in that sense, it is quite enlightening. It is, however, a weird timing a little bit for these data, because we expect that the fixed duration ibrutinib plus venetoclax will be approved at some point. But now we are getting first data that indicate maybe we should treat actually a little bit longer. On the other hand, we don't have, as I said, any PFS data, so maybe it doesn't really matter that much, this difference. So we'll definitely see. But I think it's the FLAIR study is really very intriguing in having this MRD guidance in a randomized setting now, and also because it has a comparison with continuous ibrutinib and also eventually with the chemoimmunotherapy. It really will be very informative, maybe in 2 or 3 years, to really tell us whether this whole MRD guidance at the end benefits the patients, or whether a fixed duration approach for an all-comer patient population is the more sensible approach.
Yeah, you're absolutely right. If I correctly understood, the approval for the ibrutinib and venetoclax combination would be so far fixed duration, but I'm not sure if in the future it would be feasible to apply a more personalized approach and base our decision of stopping treatment on undetectable MRD data. So I think that in the last meeting, we made great progresses in terms of first-line treatment of our patient with CLL. And we are probably shifting also in first-line away from chemoimmunotherapy combination to targeted agents administered through a fixed duration regimen. So to avoid the occurrence of resistance, and probably retreat the patients with the same combination. Even though the data are still, unfortunately, only few on retreatment in both ibrutinib and venetoclax combination and venetoclax plus obinutuzumab combination. But still now, I believe that there is a very important unmet clinical need that is represented by patients who have already received BTK inhibitors and BCL2 inhibitors. And these are a very high-risk population, meaning that we have very limited treatment options in the standard of care. And I was very excited about the results presented on pirtobrutinib, that is an oncovalent BTK inhibitor that demonstrated to be very effective even in patients without previously exposed to BTK inhibitor and BCL2 inhibitor, with and without so-called resistance-associated mutations, including mainly BTK C481S mutations.
Yeah, I think this whole avenue of non-covalent BTK inhibitors and pirtobrutinib is one example of several that are currently in clinical development. I think that it's a very intriguing principle, and definitely based, particularly as you alluded to, the fact that they seem to work also in the presence of specific BTK mutations or pathway aberrations. It's definitely addressing a key group of patients that currently now are at particular risk of having adverse long-term prognosis at the moment. So definitely very intriguing data. I think the problem that we still have, and even now with this data cutoff that was unfortunately not much longer, I think, than what was shown before. So we are still at a median observation time of around about 9 months. So it is relatively short still. So we can't really report any median PFS so far, or even a 2-year PFS can't be really reported robustly. So we definitely see in terms of the overall response rates, high response to it. So almost 70% of patients respond to the monotherapy, even though many of those, as you said, have BTK mutations. Many of those are actually double refractory also to BCL2 inhibitor. And despite that, we do see this good efficacy. And so far, the majority of patients, over 70%, I think, are still in remission 1 year after treatment. So 1 year after 1 year of treatment exposure. So definitely very promising. I think also in terms of tolerability. The whole concept of non-covalent mechanism seems to reduce these kind of toxicities that we know with BTK inhibitors, particularly the cardiovascular toxicity. All of this does not seem to be, so far, at least with 1 year observation, seem to be very prevalent. And what's quite promising to me is that even things that we see early on, usually, for instance, with ibrutinib, like this increased rate of bleeding or even mild hemorrhages, is something that we usually pick up in studies quite early on. And even though the study has 600 patients or so, the BRUIN study, we don't see any substantial numbers of hemorrhages so far. So this really indicates to me that this non-covalent property does really impact also on the toxicity profile. For now, it seems to me at least. But again, I think it all comes down to longer follow-up. I would say after maybe 2 years of observation time or so, usually the period where we get most mature data, let's say median observations between 25 to 35 months, are usually sufficient in the context of CLL to get good signals in terms of toxicity and efficacy. I think then we can be more confident also as to how we place it, again, in the context of fixed duration treatments. Can we use pirtobrutinib also in combination with venetoclax? All of these questions are coming up now, of course, and I think Anthony also showed it in his presentation that this is also where the next clinical studies will be conducted. So combining it with venetoclax and rituximab, for instance, in the relapse setting, doing head-to-head comparisons with ibrutinib, and eventually also doing this in the frontline setting.
Great, let's see. I totally agree. They sounds promising, but we need more solid and longer follow-up to confirm these initial positive results. But I was also positively impressed by the fact that the tolerability profile seems quite better than the standard tolerability profile of BTK inhibitors. And also, as poster, it was presented analysis of combined acalabrutinib studies focusing on so-called high-risk patients, meaning patients with unfavorable disease feature like 17p deletion, TP53 mutations, unmutated immunoglobulin genes, and complex karyotype defined as the presence of 3 or more aberrations, and they actually combined these different studies in first-line and relapse refractory setting, and they reached more than 800 patients and analyzed overall response rate, progression-free survival, and overall survival in different categories. I was also impressed that the data in the treatment-naive setting, meaning the analysis in 320 patients who have received acalabrutinib or acalabrutinib plus obinutuzumab in first line, show more than 90% overall response rate and over a 4 years follow-up, a progression-free survival and overall survival that was very similar to what is published for ibrutinib in 17p deleted patients or TP53 mutated patients. So I don't know if you have experience with acalabrutinib, if you are using it frequently, if this is also your impression in clinical practice.
Yeah, I think definitely we are using more and more acalabrutinib, particularly in patients who get set up on a BTK inhibitor for the first time. At the moment, most patients do get acalabrutinib rather than ibrutinib, simply because also, as you alluded to, a slightly better toxicity profile, as far as we know, particularly from the ELEVATE-RR study, which is, I think, so far the most mature data set that we have for next generation BTK inhibitor against first generation BTK inhibitor. So therefore, most patients that get de novo BTK inhibitors for us do get acalabrutinib at the moment. And so far, across all studies that we've seen with acalabrutinib, it seems that the efficacy profile is very comparable to what we see with ibrutinib. Of course, always difficult given different patient populations and all the caveats that go along with this. But I think this pooled analysis, again, confirms the overall impression that we also get from the individual studies, that in patients who have high-risk features such as TUT3 aberrations, but also complex karyotype, continuous BTK inhibition does provide very good disease control. And it seems, at least with the data set presented here, that there is also not a big difference compared to patients who don't have these high-risk features. Although I should say that, again, it depends probably also a little bit on the follow-up and on the patient population that you have. But for instance, for the unmutated IGHV status, again, it does seem to be the case that you might see slight differences, for instance, in the relapse refractory setting, more so than the frontline setting. But generally, I think, again, it confirms the notion that continuous BTK inhibition seems to provide good disease control for these very high-risk groups of patients, at least when it comes to PFS.
Thank you so much, Othman. And last but not least, I wish to discuss with you the results of the SHINE study, meaning that in the setting of mantle cell lymphoma, that is a completely different disease compared to CLL, which usually follows an indolent clinical course, while mantle cell is definitely more aggressive. And at this last EHA meeting, the results of the comparison between bendamustine and rituximab and bendamustine, rituximab and ibrutinib in first line were presented and documented a statistically significant improvement in terms of progression-free survival in patients receiving the combination with ibrutinib. So I'm always wondering if there is one arm missing, meaning that if we should have had an arm with ibrutinib single agent or ibrutinib plus rituximab but without chemo. And I don't know if in your opinion these results are going to change in clinical practice the first line treatment of patients with mantle cell lymphoma.
Yeah, it's really a massive effort, definitely, the SHINE study, given the very long observation time they had to collect this, the sufficient number of events to do this comparison. So it's definitely a very impressive piece of work. But I think, as you say, it's difficult to really say whether, and I think there have been lots of discussions on this in the past few weeks as to how much this changes now the treatment, the frontline treatment approach for patients who are elderly or unfit and who are not eligible for autotransplant in the frontline setting. But as you say, the problem is, on the one hand, we don't know how much BR then adds in this patient population. Of course, in mantle cell lymphoma, it might be a little bit different to CLL, the role of chemotherapy there. And also in CLL, we've had in the relapse setting a very similar study in some way, which the Helios study which also compared BR plus I against BR without I with placebo. And that at the end, we had the same problems, and no one is using BR plus ibrutinib, or has been, as far as I know, at least. I haven't done it, at least. Because exactly as you say, you don't know how much the BR adds. But in CLL, we are quite certain that the monotherapy is sufficient. I think in mantle cell lymphoma, it might be a little bit different. But there are, of course, a lot of other questions that came up, which, for instance, the question of, because we use ibrutinib already and have been for several years in the relapsed setting. So in the first relapse of mantle cell lymphoma, you can use ibrutinib as a very good salvage treatment. And it seems that the PFS that we've seen so far in the relapse setting is approximately the same as the PFS difference that we see here in the frontline setting between the two arms. So the question is whether if we just wait for the relapse after BR and treat then with ibrutinib, do we get the same PFS too, so to speak, as if we would treat the patients for several years with ibrutinib? Because the study again clearly shows that ibrutinib also in this elderly patient population is not very easy regimen at the end. A lot of patients, I think almost 40%, discontinued within the first 2 years because of toxicity. So it's a challenging regimen to propose it because it is a continuous regimen that you give for several years. And so my take is, at least as far as I can tell from the data that I've seen and from the discussion that I've heard, that it's probably won't change the approach for all patients. I think there might be certain subgroups, although even patients with high-risk disease did not seem to be benefiting from this tremendously, particularly in terms of overall survival. So I think it will still remain a very individual decision as to who would get BR plus ibrutinib, but I think it probably will not change, at least in Europe, most treatment guidelines. is my assumption.
And also, it may be challenged in the next future, again, by the combination of ibrutinib and venetoclax in first line, because I have seen that there were studies and additional studies are currently ongoing using this combination also in mantle cell lymphoma in first line and obtaining very impressive results with this chemo-free combination. So I think we discussed a lot about the most relevant abstract presented the last meeting. We got very good news for our patients, I just say, with CLL and mantle cell lymphoma as well. So I hope in the next future, with longer follow-up, we will confirm these initial positive results and we can use this new treatment repertoire clinical practice. So thanks a lot, Othman, for sharing with us your consideration. It was a great pleasure to discuss with you today.
Thank you, Lydia. Thank you for having me.
Thank you very much, Dr. Al-Sawaf and Dr. Scarfò, and thanks to you, the listeners, for joining us. As a reminder, to view the full program and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.